Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Isla Mackenzie in Dundee, Scotland, UK, and Professor Sunil Badve in Sydney, New South Wales, Australia, with whom we would like to discuss whether or not to lower plasma uric acid in patients without gout for prevention of cardiovascular disease or for protection against chronic kidney disease, CKD progression, based upon their CKD-FIX and ALL-HEART studies. Isla, Sunil, we are honored and blessed to host you tonight. Professor Isla Mackenzie is Professor of Cardiovascular Medicine and Honorary Consultant Physician at the University of Dundee and Ninewells Hospital, Dundee. Her major research interests include cardiovascular safety of drugs, clinical trials, hypertension, and technology in research. And her major clinical interests include hypertension and adrenal disorders, including phaeochromocytoma. Professor Mackenzie has been involved in leading a number of randomized clinical trials, including FAST, TIME, and ALL-HEART, which tested whether allopurinol treatment reduces cardiovascular events in patients with ischemic heart disease without gout. ALL-HEART has been published in Lancet after its presentation by Professor Mackenzie at the last ESC meeting in Barcelona. And after quite a lot of planning, we are now happy to finally host Professor Mackenzie a few weeks before the next ESC meeting in Amsterdam. Professor Sunil Badve is nephrologist at St. George Hospital, Sydney, and conjoined professor at University of New South Wales Medicine and Health. His primary research focus are clinical trials, meta-analysis, and epidemiology, particularly within the field of progression of chronic kidney disease, anticoagulation, and treatment of cardiovascular disease in CKD. He is lead author of the CKD-FIX trial, which tested the nephroprotective effects of allopurinol in CKD patients without gout. CKD-FIX has been published by Professor Badve in the New England Journal of Medicine 3 years ago, and it will substantially affect this year's KDIGO CKD guideline update, a draft of which has been published a few weeks ago. My co-moderators are both experts both in nephrology and rheumatology, Professor Kirsten Groth in Offenbach, Germany, and Professor Andreas Kronbichler in Innsbruck, Austria, to whom I now switch over the mic.
Well, thank you, Gunnar, for this long introduction. I think we are starting with a short presentation of the ALL-HEART study, and I would just switch over to Professor Mackenzie for the presentation.
Thank you very much for the invitation to present today. I'm really pleased to share these results. It's an important study, and it's great to share it further. So the ALL-HEART study asked the question, does allopurinol improve cardiovascular outcomes in patients with ischemic heart disease? We randomized 5,937 patients from the UK with ischemic heart disease to either receive allopurinol up to 600 milligrams added to their usual care, or to continue their usual care. It was a prospective randomized open label blinded endpoint design, and the primary endpoint was a composite of MI, stroke, or cardiovascular death. We used some remote follow-up aspects in the trial, and we supplemented reporting of serious adverse events and potential endpoints by obtaining record linkage data from national databases in Scotland and England. So why did we do this study? Well, this study started quite a number of years ago, and at the time, there were various published observational studies that gave differing results, often confounded and with biases. So it was really difficult to know whether allopurinol was actually helping patients with cardiovascular disease or not. There were various small interventional studies, but all of which had less than or equal to just 100 participants. Some of these studies reported improvements in blood pressure, endothelial function, left ventricular hypertrophy, or carotid intima-medial thickness. Some reported benefits in patients with acute coronary syndrome or after coronary artery bypass surgery. There was a suggestion in some of the articles that higher doses may be needed, so 600 milligrams daily, to achieve some of the benefits. And we had a study as well done in Dundee that had shown improvement in chest pain and exercise time in patients who had chronic stable angina with documented coronary artery disease when they were given 600 milligrams of allopurinol. So ALL-HEART was the first large prospective randomized trial of the effect of allopurinol on major cardiovascular outcomes in patients with ischemic heart disease. The study was funded by the NIHR HTA programme in the UK, and it involved more than 400 GP practices across Scotland and England. So the aim of ALL-HEART was to determine whether allopurinol improved cardiovascular outcomes in patients with ischemic heart disease but no history of gout. As I say, it was a probe study, multi-centre trial in at least 5,215 patients with ischemic heart disease, randomised to allopurinol or usual care. These are the inclusion and exclusion criteria. So you can see that we included patients who were aged 60 or over. It was quite a pragmatic trial. They had to have a background of IHD classified as MI, angina, or other evidence of ischemic heart disease. And we excluded anyone that we knew had a history of gout, people with severe renal impairment, anyone with moderate to severe heart failure, and various other categories which are listed here. Of note, we also excluded people who'd had a serious adverse skin reaction to a drug in the past to try and minimise the risk of severe Stevens-Johnson syndrome or epidermal necrolysis. We also excluded people with malignancy of significance within the last 5 years. So we recruited the patients between 2014 and 2017 from 424 GP practices across the UK. We searched for suitable patients, then they attended a single study visit with a research nurse where they were consented, screened, had screening bloods taken, and were then randomised in a 1-to-1 ratio to the allopurinol arm or the usual care arm. The dose escalation is given here. So for people with eGFR greater than 60, they got 100 milligrams for 2 weeks, then increased to 300 milligrams a day for 2 weeks. And then if they were tolerating it, they went up to 600 milligrams daily, given as 300 milligrams twice daily. For patients who had a slightly lower eGFR, they had 100 milligrams daily for the first 2 weeks, and then were increased to 300 milligrams daily, and that was the maximum dose those patients received for the study. But the majority of patients had an eGFR greater than or equal to 60. For the people in the allopurinol arm, they had bloods taken at 6 weeks, just to check their urate and use an ease and full blood count. We then followed them up annually for gout flares, skin rash. These were self-reported, adverse events, adherence with the randomised therapy, quality of life questionnaires, one general and one specific to angina, and health service usage. And this, as I say, was also supplemented with record linkage for hospitalisations and deaths. The follow-up period ended at the 30th of September 2021, and patients stopped their medication when that period finished. So here are the primary and secondary outcomes. So as well as the composite primary outcome, we looked at the components of that. We looked at all-cause mortality and various types of cardiovascular hospitalisation and quality of life. We also did a cost-effectiveness analysis. So these were the baseline characteristics of the patients in the allopurinol and the usual care group. And you can see that the groups were well balanced. The mean age was around 72, about 75% were male. And you can see that at baseline, the serum uric acid was 0.35, 0.34. Some patients had much higher uric acids and some had much lower. There was no selection on the basis of uric acid at screening time. And you can see a significant proportion, nearly half had a history of MI, more than half a history of angina, and more than half other evidence of ischemic heart disease. Another thing to note is that the patients who entered the trial had had a median of 10 years of ischemic heart disease, so they were not particularly acute coronary patients. Again, this just lists the background conditions that the patients had at the time of screening. We had just over 20% with diabetes, mainly type 2. You can also see that these patients were pretty well treated at baseline, so they were already, 90% of them were on statins and nearly 90% on antiplatelet drugs, as you might imagine for an ischemic heart disease population. So we had 5,721 participants in the modified intention to treat analysis. We had an average follow-up time of 4.8 years. There was a slightly differential dropout from the allopurinol group and the usual care group, as you might expect. And by the end of the trial, 57% of participants in the allopurinol arm had withdrawn from randomised treatment. Most commonly taken dose of allopurinol was indeed 600 milligrams daily as planned, and the mean serum uric acid levels fell from 0.34 at baseline to 0.18 at 6 weeks. So we got a significant reduction in uric acid levels with the allopurinol, as you would expect. We exceeded the target number of primary endpoints required for the analysis, and we over-recruited compared to the 5215 patients we had originally planned to include. And this shows the primary outcome result. So there was no difference between the allopurinol and the usual care groups in terms of the primary composite outcome, with a hazard ratio of 1.04. Looking at the secondary outcomes, again, no difference at all in non-fatal MI between the groups, non-fatal stroke, cardiovascular death, or all-cause mortality. And this table, again, just lists the rest of the secondary outcomes and the primary outcome. And again, no difference in any of these outcomes between the two groups. We did some pre-specified subgroup analyses for the primary endpoint, and you can see that we looked at baseline urate. Again, that made no difference. Baseline eGFR, age, sex, whether they had diabetes or not at baseline. Also myocardial infarction at baseline, heart failure, peripheral arterial disease, stroke, and stroke or transient ischemic attack at baseline. Quality of life, we found no statistically significant effect on the general quality of life or angina-specific outcomes, except there was a nominally significant change in the usual care arm in the physical domain score, slightly in favour of allopurinol. The health economic analysis has now been completed, but as you can imagine, there was no health economic benefit identified because there was no difference in the outcomes. So here I've just included the fact that we did do a complementary on-treatment analysis, although the main analysis was intention to treat, but we basically again found no difference. This can be biased because there was differential dropout between the groups, but again, there was no difference. The only one that showed significance was heart failure, and the numbers were relatively small there. Safety analysis, there was no difference in new cancers or all-cause mortality between the groups. And we had a similar number of SAEs in both groups, and we had no fatal treatment-related SAEs. So in conclusion, in the ALL-HEART study, allopurinol therapy added to usual care did not improve cardiovascular outcomes in patients aged over 60 with ischemic heart disease but no gout. We had no major safety issues identified with the long-term use of allopurinol, but bearing in mind that not all patients stayed on the treatment, largely due to stopping it if they got a rash and other side effects. The study provides no evidence for the use of allopurinol to prevent cardiovascular outcomes in patients with ischemic heart disease. I think that's my last slide on ALL-HEART. It's published open access in The Lancet if anyone would like to look at the full paper.
Excellent. Thank you very much for this great presentation. And the first question I was thinking about is, why did you in 2016 then include patients with a GFR below 60? I mean, our patient population with kidney disease usually have higher uric acid levels, and of course they have a huge unmet need, so it's very much in favor that you included these patients. But why did you change the protocol?
Yeah, so initially we only included patients with an eGFR greater than or equal to 60. That was largely due to pressure from health professionals, GP acceptability, and really discussions with our sponsor at the time. We actually wanted to include patients with some renal impairment right from the start, but there was quite a lot of pressure at that time to get the trial going, show that it was safe in the patients who had more normal eGFRs. And then we decided to extend to make it more generalizable to patients with eGFR down to 30, but we did reduce the maximum dose we gave of allopurinol for those patients. But in the end, the majority of patients in the trial actually did have an eGFR greater than 60.
Next point is, of course, the dosing. And I think you are aware that there is a lot of, debate among nephrologists how to start allopurinol. And I just had a look at UpToDate, and they recommend that once you have a patient with an eGFR of around 30, you should start with a maximum dose of 50 milligram. But what we do see in clinical practice is if a patient is on a high dose, they barely have a new side effect, because I think the most common side effects, which are life-threatening, are more idiosyncratic. So what was the rationale to start with a higher dose, actually?
Yep, so we chose a starting dose of 100 milligrams, which is fairly standard in the UK for most patients who need allopurinol for clinical reasons. And we didn't get any resistance, I would say, from anyone about using that dose in the other patients with some renal impairment. In fact, we found that most of the nephrologists that we consulted with in the UK about the design of the trial were actually quite relaxed about giving allopurinol to these patients at higher doses, more so than perhaps general practitioners who would be putting their patients into the study. So it was a bit of a compromise in the end, what we chose to do, but we never felt that we needed to start at a lower dose than that. And indeed, I don't think we did get any major issues with starting at 100. In fact, in the second year of the trial, we had a temporary shortage of 100 milligram tablets in the UK. So we had to amend the protocol temporarily to start people on half of a 300 milligram tablet. That just lasted for a few weeks, and then we got supply again.
Mm-hmm. Yeah, that's perfect. I mean, you mentioned it that around 57% actually stopped taking allopurinol in the active treatment arm. And I've read that, you know, this was mostly driven by adverse events. Around 28.6% have stopped allopurinol due to side effects. And then it was patient preference, which has been around 15%. So can you give us some insights? What were the most common adverse events?
Yes, so the way we designed the study, we actually trained our nursing staff that if a patient reported any rash that might possibly be due to allopurinol, we should err on the side of caution and stop the treatment straight away. So patients were pre-warned that if they got a rash, we would stop their treatment. We also had a very low threshold for stopping treatment because we did not want to cause a severe case of skin reaction in this trial. And indeed, as I said, we didn't actually have any major issue with Stevens-Johnson. So there was a low threshold, I think, mainly from the rash perspective for stopping. There were some patients had other side effects with allopurinol, as you might imagine. I mean, it's a well understood drug. So gastrointestinal upset would have probably been the second most common. And then patient preference, that wasn't really to do with adverse events. It was just that the patient decided they didn't want to take it anymore for various reasons.
Did you have any chance to oversee that decision-making, or was it mainly the GP office which took care of that?
Yep, so this was a trial where we could very well manage the whole thing. We had very good electronic systems, so myself or other team members in Dundee could advise if there were problems locally. And we had a very good electronic system that allowed us to review things, and we could contact patients directly to discuss their symptoms or their rash, and sometimes we would direct them towards their local GPs because we felt someone needed to look at their rash and make a decision. But we did have a low threshold, and if we couldn't be sure it wasn't allopurinol, we would stop it.
Another question from myself is, you mentioned it that the uric acid concentrations, as we would expect, went down with allopurinol. But nonetheless, so I found it very interesting that the frequency of new onset gout was basically balanced between the two groups. Do you have any more insights for us on that?
Yep, so this was self-reported new gout. So I think that we have to bear in mind that the data may or may not be completely accurate, because what patients felt was gout is open to interpretation. So I think we need to treat this data with a degree of caution. We did find, I think it was after the second year in the study, that the group on allopurinol reported less new gout than the other group, which is again what you might expect. These patients start with a higher risk than average of developing gout at some point. So that probably correlates with what we might expect. But yes, because it was patient self-reported, it is open to some subjectivity.
So you mentioned that skin rash was, of course, more common in the allopurinol group. Did you observe any patients with Stevens-Johnson syndrome?
Yep, so I'm aware of approximately 3 or 4 patients who had Stevens-Johnson. So For example, a patient who had mouth ulcers just beginning to develop and was still in primary care, never required hospitalization, but we immediately advised to stop the drug. So it was very mild, and it just got better. But that's the general advice with allopurinol, that if you stop it quickly, when the symptoms start to develop, then hopefully it will never develop to the severe Stevens-Johnson. So I think it's awareness of not taking that risk if someone begins to develop it, stopping it very quickly and getting attention. And obviously, I should add that the ethnic mix in this study was actually about 99% white. That's not what we wanted, but that's what we ended up with. And if we had more, for example, Chinese participants, we would probably have seen a much higher instance of skin reactions.
I would have two brief questions. So the first one, surely also alluding now to CKD-FIX, will you be able to get any information on incident or progressive chronic kidney disease in your study? And the second question would be, you said that there have been a couple of studies that suggested some symptomatic benefit also from Dundee. Are there any patients remaining in whom you would consider to give allopurinol?
Okay, so the first question first about renal progression. So we had hoped to do some work on that, but we would need to access more data from centralized databases if we want to do that. So we only checked urea electrolytes at baseline, and then again at 6 weeks in the patients who attended for that appointment in the allopurinol arm. So we don't have the long-term use and ease, but they are collected nationally in Scotland, so we could potentially access that data in due course and match it with the right permissions. We didn't see a difference in renal SAEs between the two groups, so I suspect we wouldn't find much, but we haven't yet done that work. We are doing some further analysis in our other study, FAST, looking at renal outcomes. The second question was, do I think there are any patients in whom it could be given? Well, it's an interesting question.
From a cardiological standpoint, surely in the field of rheumatology, everybody would still give allopurinol and gout, but yeah. You as cardiologists, do you see still some indication?
So for gout, yes, definitely, obviously. We didn't include any patients who were known to have gout, so we can't comment on patients who have ischemic heart disease and gout from this data. It could be that there's a difference in symptomatic improvement and outcomes, as there is in a lot of cases with angina treatments. They either improve outcomes or they improve symptoms. So there was this study looking at angina, and it did seem to help symptomatically. We didn't see a difference really in the Seattle Angina Questionnaire responses, which we might have expected to see if there had been a big difference. So I'm not sure that we would expect a big difference, and I wouldn't personally continue allopurinol in these patients with ischemic heart disease. That would be my view. There were a small number of patients who strongly wished to continue it because they felt much better on it. And that was left to be an individual decision between them and their GP after the study finished. And I'm aware of a small number who chose to stay on it on clinical grounds, whether that's evidence-based or not. But we made them aware of the results of the study. We made all the patients who'd taken part aware of what the study had found and that there wasn't an outcome benefit.
Thank you very much for the beautiful presentation, Professor Mackenzie. And we'll sort of multiply this into the chronic kidney disease now. Before you present your slides, Professor Badve, I would be very interested if you could briefly remind us of in what way hyperuricemia damages the kidney. What was our idea when we started such a trial? Why should we sort of have the idea of lowering? What happens? What does urate do to the kidney?
Yeah, so there had been a lot of clinical or epidemiological studies linking hyperuricemia with a variety of adverse kidney outcomes. And at that time, there were at least 2 or 3 animal studies that showed that inducing hyperuricemia in animals caused kidney damage. And when these animals were given allopurinol, that prevented kidney damage. So by the time when we designed the study, there was a strong epidemiological and preclinical data, and also a small number of very small single center trials.
I think that's very important, that there really was evidence, and quite strong evidence, to say that controlling hyperuricemia could benefit or could present a benefit for the kidneys. So we are very
That's great.
happy to see your trial, the CKD-FIX trial, which did a little bit a parallel design for the kidneys.
So thank you very much for inviting me at this meeting. And on behalf of all investigators, I'm pleased to present the results of CKD-FIX trial. So elevated serum urate levels are associated with increased risks of onset and progression of chronic kidney disease and kidney failure. Several observational studies have demonstrated a linear association between serum urate levels and various outcomes, including albuminuria, onset of chronic kidney disease, progression of CKD to kidney failure, cardiovascular events, and even death. Serum urate levels increase linearly with decreasing GFR due to reduced excretion. Therefore, elevated serum urate levels are very common in patients with chronic kidney disease. Thus, it is unclear whether elevated serum urate levels play a causative role in kidney disease progression, or urate is just an indirect marker of decreased kidney function. Single center trials have demonstrated that urate lowering treatment with allopurinol or febuxostat could slow CKD progression over a short follow-up up to 6 to 12 months. We published a meta-analysis evaluating the effects of allopurinol on kidney outcomes in 2014. In this meta-analysis, we included 8 randomized controlled trials that enrolled 476 participants with a median sample size of 57 patients only. Allopurinol was compared with placebo in 2 trials, and there was no study medication in the control arm of the remaining 6 trials. The median follow-up was only 11 months, and the mean difference in change in GFR from baseline to study completion between the allopurinol and control arms was 3.1 ml per minute. Although the 95% confidence intervals crossed 1, the treatment effect was in favor of allopurinol. Therefore, we conducted the CKD-FIX trial to test the hypothesis that urate-lowering therapy with allopurinol would attenuate the decline in eGFR over a period of 104 weeks in patients with chronic kidney disease. This was an investigator-initiated trial, randomized, double-blind, and placebo-controlled trial. We received funding from the National Health and Medical Research Council of Australia and Health Research Council of New Zealand. The study was sponsored by the Australasian Kidney Trials Network and was conducted across 31 centers in Australia and New Zealand. Adults with stage 3 or 4 chronic kidney disease, that is GFR between 15 to 59 ml per minute, deemed at increased risk of CKD progression were eligible to participate in the trial. The increased CKD progression risk was defined as urine albumin creatinine ratio greater than 265 milligrams per gram, or at least 30 milligrams per millimole, or decreasing eGFR by at least 3 ml per minute in the preceding 12 months, which was calculated as the difference between the first and the last of 3 estimated GFR tests, each test done at least 4 weeks apart. Key exclusion criteria were history of gout, allopurinol hypersensitivity, kidney transplant recipients, concomitant treatment with medications with known drug interactions with allopurinol, clinical indication for allopurinol, and unresolved acute kidney injury in the previous 3 months. Eligible patients were randomly assigned to allopurinol or placebo in a 1:1 ratio using an adaptive allocation algorithm designed to minimize imbalance across treatment groups in the following variables: trial center, CKD stage 3 versus stage 4, urine albumin creatinine ratio greater than 530 milligrams per gram or less than 530 milligrams per gram, and presence or absence of diabetes. The total trial follow-up duration was 104 weeks, and this comprised of 2 phases. The initial phase of 12 weeks was designed for dosage escalation, and the subsequent 92 weeks were for follow-up. During the follow-up phase, patients were assessed in clinic every 16 weeks. Patients were withdrawn from the trial earlier than 104 weeks if they required dialysis for more than 30 days or underwent kidney transplantation. During the dosage escalation phase, the starting dose of the study medication was allopurinol 100 milligrams daily or placebo 1 tablet daily to be taken orally. The dose was increased up to a maximum of 3 tablets daily, that is 300 milligrams of allopurinol or 3 tablets of placebo. And this increase was done every 4 weeks if all criteria for dosage adjustment were met. And I will describe these criteria in the next slide. So for an increased dose adjustment of the study medication, all of the following 8 criteria must be present. No new onset skin rash or reaction. Hemoglobin must be at least 8 grams per deciliter. Neutrophil count greater than 2. Eosinophil count should be less than 0.60 or within 20% of the previous value. Platelet count at least 100. ALT levels less than 3 times the upper limit of normal. Serum creatinine within 20% of the previous value. And the treating physician feels increasing dose is safe based on the clinical circumstances. Dose adjustment was not permitted on the basis of serum urate levels. Although there were many reasons for this, the 2 specific reasons were that no particular threshold for serum urate level has been identified for target to prevent CKD progression, and also to avoid inadvertent unmasking of the randomized intervention. All participants were instructed to stop the study medication immediately and report to the study site if a new skin rash develops. The primary outcome of the CKD-FIX trial was change in eGFR from randomization up to 104 weeks using the CKD-AP creatinine equation. We also conducted sensitivity analysis using the CKD-AP equation based on cystatin C alone or in combination with creatinine, as well as using the MDRD equation. The secondary outcomes were a composite of reduction in eGFR by 40% from baseline, kidney failure, or all-cause death. The other secondary outcomes included reduction in eGFR by 30% from baseline, kidney failure, or death from any cause. Individual components of these composite kidney endpoints, blood pressure, albuminuria, serum urate levels, cardiovascular events, all-cause hospitalization, and quality of life summary scores using short form 36. Safety outcomes included all serious adverse events and drug reactions. Specific adverse outcomes of interest were erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis, minor skin rash, hypersensitivity syndrome, aplastic anemia, and thrombocytopenia. Assuming an annual decline in eGFR of 3 ml per minute, loss of follow-up of 5%, drop-in and dropout rates of 5%, recruiting 620 patients would provide 90% power to detect a 20% attenuation in the decline of eGFR after 2 years of follow-up. This difference of 0.6 ml per minute per year is clinically meaningful and associated with a hazard ratio of 0.7 for the clinical outcome of kidney failure during subsequent years. The primary outcome was analyzed jointly with time to study discontinuation to accommodate informative dropout due to death or kidney failure before completion of the 104-week study visit. Measurements of eGFR over time were analyzed using a linear mixed model with fixed effects for treatment, continuous time, interaction between treatment and continuous time, and centered baseline eGFR. The estimates of treatment effect, that is the difference between allopurinol and placebo groups in annual change in eGFR, took into account time to discontinuation for informative reasons such as death or progression to kidney failure. Secondary outcomes were not adjusted for multiplicity. Repeatedly measured continuous secondary outcomes were analyzed using the same joint modeling approach as that of the primary outcome. The binary secondary outcomes were analyzed using log binomial regression models and Cox regression models. From March 2014 through December 2016, a total of 369 patients were randomized to allopurinol or placebo, accounting for 60% of the target recruitment. A decision was made by the steering committee to stop further recruitment due to slower than anticipated recruitment rate, which rendered participant number unlikely to reach the projected target within a reasonable time frame. This was a pragmatic decision based on trial logistics and funding, and no interim efficacy or futility analysis were conducted prior to this decision. 6 patients, 3 in each group, withdrew consent immediately after randomization. The remaining 363 patients received at least 1 dose of the assigned treatment and were assessed for the primary outcome. At the end of the 12-week dosage escalation phase, nearly 70% patients in both groups were taking 3 tablets of the assigned treatment daily. During the follow-up, 54 patients in the allopurinol in the allopurinol group, that is 30% patients, and 45 patients or 25% patients in the placebo group discontinued the treatment. 73% patients in the allopurinol group and 80% patients in the placebo group completed the total 104 weeks follow-up. Thus, the mean total on-treatment time of the total follow-up was 82.5% in the allopurinol group and 88% in the placebo group. Baseline characteristics were balanced between the assigned treatment groups, except for the primary cause of kidney disease. At baseline, the mean eGFR was 31.7 ml per minute, and approximately equal proportion of patients had CKD stage 3 and CKD stage 4. The median urinary albumin creatinine ratio was 717 milligrams per gram or 81 milligrams per millimole. 71% patients had severely increased albuminuria or KDIGO A3 category albuminuria. The mean serum urate level at baseline was 8.2 milligrams per deciliter or 0.48 millimoles per liter. Coming to the primary outcome of eGFR slope. So the primary outcome of change in eGFR in the allopurinol group was minus 3.33 ml per minute per year, and in the placebo group was minus 3.23 ml per minute per year. The primary outcome did not differ significantly between the allopurinol and placebo groups, with the mean difference of minus 0.10 ml per minute per year and 95% confidence intervals crossing zero. Additional and sensitivity analysis of the primary outcome showed similar results with no significant difference in change in eGFR between the allopurinol and placebo groups. We conducted post hoc utility analysis, and this analysis revealed that had the target recruitment of 620 patients been met, the conditional power to detect the pre-specified clinically meaningful difference of 0.6 ml per minute per year was only 1 in 1,000. Had we planned for a dropout rate of 30% from the active treatment group, the required sample size would have been 1,006 patients. The conditional power for the sample size of 1,006 patients was 17% or futility index of 83%. In other words, the probability of reaching the primary objective of the trial was still only 17% if the trial recruitment target had been adjusted for the observed dropout rate of 30%. The results of the primary outcome were consistent across a wide range of pre-specified subgroups that include patient sex, age less than or greater than 65 years, race, body mass index less than or greater than 30, diabetes mellitus, CKD stage 3 or stage 4, albuminuria, the criteria for CKD progression, cause of chronic kidney disease, diabetic or non-diabetic kidney disease, use of diuretics, and the use of RAS inhibition. There were no significant differences in the secondary outcomes between the allopurinol and placebo groups. Although the total number of deaths in the allopurinol group was greater than the placebo group, owing to the small number of events, this finding should be treated as an exploratory result only. Coming to the mean serum urate levels. So the mean serum urate levels in the placebo group at 12 weeks was 8.2 milligrams per deciliter, and it remained at 8.2 milligrams per deciliter for the duration of the follow-up. The mean serum urate levels in the allopurinol group decreased to 5.1 milligrams per deciliter at 12 weeks and remained at 5.3 milligrams per deciliter up to 104 weeks. Overall, mean difference adjusted for baseline was minus 2.7 milligrams per deciliter, or 35%, which is quite a large and sustained reduction in serum urate levels. There were no significant differences in urinary albumin-creatinine ratio and systolic and diastolic blood pressures. Serious adverse events occurred at a similar frequency in the two groups, and there were no statistically significant differences in the risk of non-serious adverse drug reactions, including skin rash. So despite a sustained mean reduction of 35% in serum urate levels in the allopurinol group, we did not observe any meaningful difference in change in eGFR over 104 weeks between the allopurinol and placebo groups. There was no effect on albuminuria or blood pressure, and our results do not appear to support the view that urate levels play a causative role in progression of chronic kidney disease. The strengths of this study include enrollment of patients with high progression risk, markedly elevated baseline serum urate levels, a large and sustained reduction in serum urate levels, and analysis involving shared parameter joint modeling approach. The study also has a few limitations, including insufficient statistical power, high percentage of patients discontinuing trial regimen. We used surrogate outcome based on serum creatinine-based eGFR equation and not a measured GFR. And to conclude, we did not find that allopurinol was more effective than placebo in slowing the decline in GFR over 104 weeks in patients with stage 3 or 4 chronic kidney disease and an elevated risk of CKD progression.
Yeah, thank you very much for this very clear presentation. I think we have seen that we have a not easy drug because we are all very aware of very difficult skin side effects. And we have seen that you have lowered serum uric acid effectively, and still we have no benefit for the kidney. I think that's quite a clear message. Can you comment on why recruitment was so difficult? Why was it slower than, or so much slower than anticipated?
Yeah, so actually to recruit 369 patients, we screened almost 10,000 patients. And because the inclusion criteria were so selective that we had to have patients at risk of progression and not have a variety of exclusion criteria, I think that proved quite difficult.
Okay. And have you got an idea why so many patients stopped the medication prematurely, which is for a clinical trial, 30% is quite a lot, isn't it?
It might sound quite high, but if you look at the ALL-HEART study, in fact, more number of patients stopped allopurinol. And we have seen this with allopurinol previously as well. So if you look at CARES trial, the 56% patients in the allopurinol group and 57% patients in the febuxostat group stopped study medication. So in comparison, the proportion of patients stopping allopurinol in the CKD-FIX trial were much less, but still 30% is quite high. And we did not find any specific reason. The reasons were sort of fairly distributed between physician request, patient request, and adverse reactions. So there was no clear reason why patients stopped study medication. But despite such high discontinuation rate, the on-treatment so patients in the allopurinol group took the study medication for almost 82.5% of the follow-up time.
Yeah, I just wonder because the rate in the placebo group was also high, and in all the studies you mentioned, it's probably a question to the two of you, because I've done clinical trials in a different setting, but this is still something that is a little bit unusual, I would say.
Could I comment on that?
Yes, please.
I think it's really interesting that even in the trials like CARES particularly and FAST, where patients had gout and therefore probably needed urate lowering therapy, the discontinuation rates are really high. So I think it's probably not surprising that in trials where it's questionable whether they need allopurinol or not, the rates are also similar.
Okay.
And to add to that is conducting trials in CKD patients is very challenging. These patients are older, they have multimorbidity, they frequently have what we call as polypharmacy.
I agree.
The pill burden is extremely high. So little bit of reaction here and there, they will attribute it to a medication and stop.
I absolutely agree. That's why we find it so important that they do not get any medication that's just useless for what was thought to be useful. And I think that's very obvious that we have to be quite clear that it's a problematic drug, and patients have already a lot of medications, and for these endpoints, at least, there's no benefit. For gout, that's a different story. We shouldn't sort of mix that up. what is your personal reason for this probably unexpected outcome? That's why I stressed the animal models in the first point, because there was evidence that it could be beneficial. But what is your personal sort of explanation? Is it the trial too short, or is it RAS inhibitors or even SGLT2 inhibitors in the future that rule out the effect that probably controlling hyperuricemia would have? Are there other drugs that are more potent for this aim that patients are on already?
So you're correct in saying that SGLT2 inhibitors have definitely shown substantial benefit on CKD progression in patients with CKD, including those at high risk of progression. And SGLT2 inhibitors also reduce serum urate levels. And there have been a few mediation analyses suggesting that urate lowering effect may be one of the main reasons of benefits of SGLT2 inhibitors. If that were to happen, we would have definitely seen some benefit in CKD-FIX trial, and we did not. So so looking at CKD-FIX trial, we try to analyze it in variety of ways, and I have started to think that urate levels are just a biomarker of decreased kidney function, because there is a clear association between urate levels and eGFR. As eGFR drops, urate levels go up. So this is probably more likely to be another biomarker of decreased kidney function rather than playing a causative role.
Okay, I absolutely agree. It just then we cannot explain why in the animal model, if we control uric acid levels by allopurinol in an animal model, why this works, or what do we control then? Do we control inflammation or anything else? Why did it work in the animal model?
So if things were going to work only in animal models, we wouldn't need clinical trials.
Absolutely agree. Okay. You're certainly aware of the FEATHER trial, which is another trial that sort of addresses the same point with febuxostat, which is another uric acid lowering agent, with basically the same result, that there was no significant benefit with febuxostat, although they saw a little benefit in a post-hoc analysis in patients without proteinuria. Is there anything that makes sense to you, that a subgroup that could still benefit from controlling hyperuricemia?
So in CKD-FIX trial, we did look at pre-specified subgroup analysis according to patients who had less proteinuria. But to begin with, in the FEATHER trial, patients had stage 3 kidney disease, and they had very, very stable GFR over the entire duration of the follow-up. In fact, if you look at the baseline GFR and end of the study eGFR, there was a flat line. So there is really no supporting hypothesis to suggest that febuxostat is beneficial in patients without proteinuria. And with small subgroup analysis, I think we need to interpret that with caution, and it's an exploratory analysis only.
Absolutely. Okay, I think that's a very good point. We just, no matter how we deal with it, we don't see a benefit of this mechanism, and we should.
And if we have 10-15 subgroup analysis, by chance at least one will show some signal.
Okay, I agree. Thank you very much.
Maybe just one commentary from me. I just read the editorial once again to your study, where it was stated that further studies are needed to prove this. And I would strongly disagree here, because I am positive that CKD-FIX really solved the question. We now know there's no benefit. We have better drugs. I would, even though we are aware of your time, I would like to take the opportunity, Isla, and to ask you to shortly comment on a very important second comparison. You made another study some years ago where you compared allopurinol and febuxostat. And might we briefly ask you to tell us about the main findings from that trial?
Yes, so we did the FAST study, which was looking at the cardiovascular safety of febuxostat versus allopurinol. At the same time, the CARE study was running in the United States, which published before FAST. FAST was the European study requested by the EMA. So this study was funded by Menarini, but run by the University of Dundee, and it was an academic design study. So we actually found that febuxostat was non-inferior to allopurinol with regard to the cardiovascular outcomes. But interestingly, although it didn't quite reach significance, if anything, we saw febuxostat was possibly slightly better than allopurinol, which was the opposite to what CARE suggested in some of their secondary outcomes, although their primary outcome was very similar. They were slightly different study populations. The CARES people were slightly different. They had more cardiovascular risk. But we did also look at the FAST population who were quite similar to those in CARES. And again, we found the same result. I think one of the issues with CARES was the loss to follow-up. About 45% of their patients didn't complete follow-up. And when they actually got a private investigator to try to find out more about the deaths that had occurred, the difference in deaths went away that they had initially reported. So I think, personally, I think FAST is possibly the more reliable study with much better follow-up and less treatment discontinuation. So I think febuxostat, there were a lot of warnings came out about febuxostat based on the CARES results, which I think are now beginning to be reversed based on the FAST results. Certainly the MHRA in the UK has published updated guidance based on taking into account the FAST results as well now.
Thanks so much. So my last question before turning the mic again back to Andreas for some final looks into the future. To all of us, or to all of you actually, do you believe there's a level of uric acid where we should still use allopurinol in kind of prevention? So if it's up to say 12 or 15 or something like that, or should we really, after these two major trials, say, well, there's no benefit ever been shown, so just keep it untreated?
Yeah, so I think it's clear that if you have gout or problems with your kidneys due to uric acid, which is relatively rare compared to gout, I think it's quite clear that patients will potentially benefit from treatment. I don't think...
Sorry, I have to specify again, I'm thinking about asymptomatic.
Asymptomatic hyperuricemia, I don't think we have enough evidence to say we should treat that at the moment. I know in Japan, I think febuxostat's licensed for that use. It's not licensed for that use in Europe and UK, as far as I know. So I think we didn't necessarily include people with the very highest levels of uric acid in ALL-HEART because we excluded anyone who'd had a history of gout. So from ALL-HEART, I can't specifically comment on that, but my overall impression is that we shouldn't probably be treating asymptomatic hyperuricemia at the moment based on the evidence we currently have.
May I probably...
Yeah, in the
rheumatologist's perspective, we know that if you, as a male, your uric acid is above 12 milligrams per deciliter, as a female above 9 milligrams per deciliter, that the risk of gout or having a gouty attack is probably 10% per year. But still, even if you get one gouty attack, that doesn't mean that you convert into chronic gout. So nowadays, guidelines say that even with one attack, you do not necessarily have to tackle the uric acid problem. Only if 2 attacks or more, then you have to lower the uric acid serum level. And that has changed over the time. When I was training in rheumatology, everybody above 10 milligrams per deciliter had the allopurinol tablet sort of booked. But we have refrained from that because there are a lot of people who do not get a second hit of gout. Or the only the rheumatology guidelines are quite firm there, and they say only if you plan a chemotherapy or radiotherapy and have such a high level of uric acid because of cell lysis, then you definitely get a problem, can get a serious kidney problem. But other than that, no prophylaxis with high levels of uric acid.
We conducted some post hoc analysis according to baseline serum urate levels. So we divided patients into hyperuricemia, normouricemia, And we also divided patients into tertiles so that there will be equal proportion of, so there will be 3 cohorts, the lowest tertile, middle tertile, and highest tertile. And in the highest tertile, the mean serum urate level was 10.1 milligrams per deciliter. In fact, we found greater reduction in the urate levels in the allopurinol group in the highest tertiles, and it still had no effect on eGFR. So for asymptomatic hyperuricemia, I would not recommend, even if urate levels are greater than 10.
Well, thank you. That was great. And I think that's very helpful for us in clinical practice. So we are moving a bit away from urate. And as Gunnar mentioned, and I had a look at the Australasian trial network yesterday, and it's really impressive how many studies are ongoing at the moment. And congratulations to that. We are particularly, of course, interested in a reduction in pill burden, and one of the drugs or problems we are facing in nephrology, which causes a lot of prescriptions, is of course phosphate. And we are aware of the phosphate trial. So where are we standing here in terms of recruitment, and when can we expect the first preliminary results?
Okay, so in collaboration with investigators from Canada, UK, New Zealand, Australia, Brazil, and Israel, we are conducting a phosphate trial, which is sponsored by the Australasian Kidney Trials Network. The key eligibility criteria include kidney failure patients treated with dialysis for at least 3 months, age over 45 years, or if they are diabetic, age over 18 years, and they need to be treated with at least 1 phosphate binder. The interventions are patients are randomized to either intensive phosphate control, so to aim the phosphate levels less than 1.50 millimoles per liter, or liberalized phosphate control when phosphate binders are prescribed as a rescue treatment only if phosphate level is greater than 2.50 millimoles per liter. Now, this is a pragmatic open label trial, and the primary outcome of this trial is major adverse cardiovascular events, which is a composite of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, coronary revascularization, or a peripheral artery disease events. And the sample size is 3,600 participants. There had been significant delays in patient recruitment because of the pandemic. And now that the pandemic is past us, we have focused on patient recruitment again. It will still take another 3 to 4 years to complete the recruitment and follow-up of this trial.
So the next one is the TRACK trial. I think Gunnar mentioned that he is very much into anticoagulation.
Yes, so the TRACK trial is sponsored by the George Institute for Global Health. And the key eligibility criteria for TRACK trials are age over 18 years, advanced chronic kidney disease such as CKD stage 4 or 5, or kidney failure treated with dialysis, and at least 1 cardiovascular risk factor, which is defined as age over 65 years, diabetes, previous history of myocardial infarction, stroke, or peripheral artery disease. And patients are randomized to low-dose rivaroxaban, that is 2.5 milligrams twice daily, or matched placebo. The primary outcome is major adverse cardiovascular events, which is a composite of cardiovascular death, myocardial infarction, stroke, or peripheral artery disease events. And we are also looking at safety outcome, which is major bleeding. The sample size is 1,900 participants, and currently the study is recruiting patients across 11 countries, including Germany, France, and Belgium in Europe, Canada, Tunisia, Saudi Arabia, India, Malaysia, Singapore, Taiwan, and Australia.
And I think the last one is the renal life cycle one, and that's about expanding the indication of SGLT2 inhibition, I think.
That's correct. So renal life cycle trial is sponsored by the University Medical Center Groningen in the Netherlands, and the George Institute is conducting trial in Australia. Apart from the Netherlands, this trial is also being conducted in Germany. And there are 3 main cohorts in this trial. So the first cohort is CKD patients with eGFR less than 25 ml per minute on stable dose of an ACE inhibitor or ARB for at least 4 weeks. The second cohort is patients with kidney failure treated with dialysis and a residual urine output of at least half a liter per day. And the third cohort is kidney transplant patients with eGFR less than 45 ml per minute. And patients are randomized to dapagliflozin or 10 milligrams daily or placebo 1 tablet daily. And the primary outcome is a composite of all-cause death, kidney failure, and hospitalization for heart failure. And obviously for patients who already have kidney failure, we will not be assessing kidney failure as the outcome in those patients. And the sample size is 1,500 patients.
Thanks so much. This was really a fascinating hour. Admittedly, it's somewhat more than 1 hour, but having the 2 of you was really worthwhile to take some more minutes. Thanks so much for doing these studies. There's no big support from pharmaceutical industry behind it. So it's even more important really that we have these data, which I would like briefly to summarize. Associations will not prove causality, and less is more. Have a good afternoon in Scotland, a good night in New South Wales, and hopefully seeing you soon again. Thank you.
Thank you very much.
Thank you. Bye-bye.
Bye.